All right, welcome. My name is Sujit Iyer. I'm the Director of Pediatric Services for U.S. Acute Care Solutions and also a pediatric emergency medicine physician here at Dell Children's in Austin, Texas. We've been asked to provide some really focused education in the context of increasing volumes, specifically on how to manage young children with bronchiolitis who may need escalating respiratory support. We're very lucky today to have two experienced providers here at Dell Children's to help us walk through care beyond the emergency department. Sam Delafield, who's a pediatric ICU physician here at Dell Children's, and Jennifer Simpson, Director of Respiratory Therapy here at Dell Children's in Ascension, Texas. So we're going to jump right into it, and they're going to walk us through how to manage these children in the ER and beyond. This is a brief primer, and so just a reminder for those who are listening to this video, this is really the standards of one local children's hospital. Depending on your geographic area and your own equipment and supplies, we'd recommend discussing what you have available with your team, as well as what your referral centers prefer in terms of treatments and guidelines for flow rates. Remember that this primer is meant to be a focus on high flow and escalating respiratory therapy. You can find further education in Litmos on the management of children with bronchiolitis, especially for those who are going home, including a standard bronchiolitis discharge education that is both in English and Spanish, a CMT, and some other recorded talks on bronchiolitis care. All right, we're going to let Jennifer talk to us about high flow nasal cannula.
Thanks, Sujit. So first, we're going to talk about what high flow is. So it is a heated, humidified source of oxygen. It is able to provide higher flows. The way that it works is it washes out the dead space in the upper respiratory tract. So that provides a mechanism so that every breath becomes 100% of the oxygen that you're delivering. It also has the opportunity to wash out some of the CO2 in that upper space. It does provide, because of that, it provides, and the added flow adds a decrease in the work of breathing, and it may provide some, although inconsistent, PEEP.
So here we're going to walk through actually how to set up high flow nasal cannula through one system. Your own equipment may vary and your own local respiratory therapist should know how to set this up, but we're going to walk through the basic steps of this, as well as the types of equipment that we use and how we then manage these settings.
At Dell Children's, we use the OptiFlow Junior 2, but all of the devices have similar mechanisms. And so you're going to have some sort of a pole to rest all these on. You'll have a blender that allows you to manipulate the FiO2. You should have at least 2 flow meters on here just for a backup and for placement of your anesthesia or ambu bag. You'll have heater brackets to hold the heater, and then there's some pigtails that go into the heater to make sure that it connects to the circuit.
Perfect. We could talk about
the disposable equipment can vary depending on which type that you use. Again, we use the Fisher and Paykel version. That version comes with a kit, but it'll essentially have a water chamber with a large bore circuit. You'll need some sterile water bag for You'll have a sterile water bag for inhalation that will support the humidity, and then the prongs that fit on the end of that large bore tubing that are sized for different patient sizes. Those cannulas do have specific flow rates, so make sure that you're looking at that before you throw away the box.
Great, that's a good point. All right, so why don't you walk us through how you would teach somebody to set this up?
So the main point of the cannula sizing and the flow is that the cannula does have to support the flow. So we do later in this presentation give you some recommended flow rates. However, going above the flow rates that are specific to the cannula can cause some shearing if run too high through the cannula. So you do want to make sure that you're paying attention to the max flow rates that are involved in here.
Great. And Jen, your audio may have just cut off for just a second here. So just, I think your main point here is just making sure that you read the box for the settings, right?
Yes.
Thanks. All right. What about the equipment setup?
Okay, so to start, you'll place the chamber on the heater. You'll add the adapter to the heater. So this is where it may vary a little bit by site, but there's usually a mechanism that will have some sort of a pop off or a control for the flow. And then the last step is putting the large bore tubing onto the adapter and then placing it on the other side of the heater. So the idea is that flow is coming from oxygen tubing, going through a pop-off valve, going through the water, collecting humidity, and then coming back out of the large bore tubing.
Great. Last couple steps here with the heater wire.
So next you'll attach the heater wire and pigtails according to the heater that you're using. Those will connect directly to the large bore tubing. There's typically a place to put it by the heater and then also by the patient so that you can identify whether the patient is getting that set humidified temperature that you're looking for.
Great. And you talk about the prongs a little bit.
When you're attaching the prongs on, again, you want to make sure that you're looking at the size of the cannula, and you want to make sure that you're not, the size of the cannula prongs inside the nose should not include more than 60% of the nair. When you include more than 60% of the nair, you could be inadvertently giving inconsistent peak levels, and so you want to have that room for the air to escape back out of the nostrils.
Great. That's a great point. And this shows maybe a little bit of it too about how you set it up on their face.
Mhm. So on these babies, one thing that we noticed is that not all babies like having cannulas on their face. We do have what are called wiggle pads that are specific to our device here, but these offer for a way to have a set interface or a set place to secure the cannula so that if the baby does rip the cannula off, it's a Velcro piece that comes off and doesn't tear their skin. We noticed that even with this, it was hard to keep the cannula on. So we have come up with a way to prevent this. If you use trach ties and go behind the back of the neck, when the baby pulls on the cannula, they'll pull on the back of that trach tie and pull kind of on the back of their neck as opposed to pulling the whole thing off their face. So just a little tip and trick that may work for you. Again, you don't want to, when you're sizing the cannula, you don't want to include more than 60% of the nairs, and you do want to watch for skin issues.
Great. Yeah. This is a really fine art, I would say, in keeping these on. Sam, I don't know if you have any other tips on what you guys focus on in ICU for these kids who've been on it for a while.
I don't think so. The wiggle pads are actually really nice because, like she said, they're Velcro. So if they do pull it off, then it just ends up pulling Velcro off of the wiggle pads, but those stay on the face. And so it's prevented us from having skin injuries related to these.
Great.
The other lesson, sorry, Suja, the other lesson that I would also say is that where the cannula kind of goes up and cinches, that piece can get pretty hard. And so you always do want that in the front, which is why we have kind of a tip and trick for how they pull it. Putting it back behind the head can be difficult and lead to skin issues if they're laying on it.
Got it. That's a good tip.
The blender is pretty simplistic. It'll just give you a readout of the FiO2. You can change the FiO2 by dialing either right or left. All of them are universal. So at the far left, you're going to be at the lowest flow rate at 20, all the way down to 21%. And then at the extreme right, you would be at 100%.
Great.
The heater, again, this is really the key for bronchiolitis and for high flow is that you're adding this warm humidified air. It is required for use for high flow cannula. Without it, you would have some drying of secretion. So you want to make sure that the heater is functioning appropriately. You can do this by looking at the alarm. We have a picture here of what our heaters look like, but they typically all have some sort of an alarm system that will alert you when there's something going on with the alarm. You do want to make sure that you are emptying any tubing water that you might see. As you can imagine, when you add humidity and it's going through a cold circuit, you can get some rain out. So emptying that circuit water will help with having a consistent FiO2. You definitely don't want to turn off the heater unless instructed by your therapist or somebody that's familiar with the heater. Just again, because that can lead to some drying. So because of these higher flows, you do not want to leave a patient unhumidified for any period of time. On the flow meter itself, it's the same type of flow as off the wall that you're used to seeing, but it uses a blender. So regardless of the liter flow, your FiO2 that's being delivered is going to be the same. So if I'm in a 2-liter cannula and I have the blender set at 50%, you're going to be delivering 50%. If I have it at 5 liters per minute at 50%, you're still going to get that 50%. So now you have a little bit of a difference between the flow that you're delivering and the amount of FiO2 that you're delivering.
Yeah, great. I think that's a really good point. I think Sam will talk a little bit. There are two separate settings that we're thinking about, both flow and FiO2, and what the kid needs may be different for each of those components. So let's get right into the do's and don'ts of high flow nasal cannula now that folks are using this more in the community.
So you do want to understand that the FiO2 is not perfect, but one of the things that we saw here early on in our high flow journey was that there was a misunderstanding of where high flow sits as opposed to our regular nasal cannula and simple masks and non-rebreathers. So this is not perfect. It's obviously going to give different FiO2s depending on the patient's size. However, just a simple guideline is 21 to 28% is usually about a 1 to 2 liter cannula. 35 to 60 is usually a 5 to 10 liter simple mask, and then above that you're going to a non-rebreather. The FiO2 on the high flow can go up to 100%, so it's always going to be giving a higher amount of oxygen on the high flow than you can on any of these systems. So switching from a high flow to one of these systems is usually going to be a downgrade. The way that we set and decide the flows are really dependent on auscultation. The way that we do it here, if you give too high of a flow rate, you can actually impede and make worker breathing worse. So you want to make sure that you're hitting just what they need for their flow demand and not going above. Since there's not a one size fits all flow demand and it's very patient specific, the way that we identify this is through auscultation. So if you're listening to auscultation and you hear what we call a CPAP whoosh, which is that loud, turbulent flow, you may need to in the chest, then you may need to decrease the flow rate. You may be delivering too much flow. Suctioning the nares to improve delivery, you want to make sure that you're doing this, but not doing it too often. So if you're doing it too often, you're going to inflame the nose and make things worse. Typically, we assess suctioning every 4 hours. Here is a general rule. Doesn't mean that they have to be suctioned every 4 hours, but you do want to keep it clear without causing any further inflammation. That can be kind of a delicate balance. You never want to ignore heater volumes. That temperature can get too high. You never ever want to turn off the flow with the heater on. So this can scald the patient. So even though the flow's off, there is a buildup of heat in that circuit, and that can transition to the nares.
Great points. And just as a reminder from previous education we've done, that when we do suctioning here, we focused on nasal suctioning with saline drops. We use mushroom tip catheters. We don't do vigorous deep tracheal suctioning, as the evidence is not great that helps. And so we're trying to clear the upper airway. Sam, I don't know if you have other thoughts on suctioning tips when you have these kids in the ICU also.
Yeah, I mean, in the ICU, all bets are kind of off, right? So yeah. Even though the data doesn't support the deeper nasal tracheal suctioning in an ER setting, when they come to us, if it's really seeming like they're just packed full of snot, sometimes really clearing that out can help them to see the flow and the support that we're giving through high flow. That is not something that I'm doing frequently, but if initially I need a one time to really try to clear them out so they can see the flow, we will do that. But again, don't want to do that too much, because then it can just worsen your problem, worsen inflammation, and make the worse off.
Yeah, thanks. That's a great point. Yeah, that's kind of for the one-off, really sick kid at one time. Yep, thanks. So let's talk a little bit about once you get these kids started on high flow and then titration specifically.
So the goal of our FiO2 needs is really, when you're looking at FiO2, you want to make sure that you're hitting 90%. Once you hit 90% SpO2, there's really not any benefit that you're getting out of giving them more. As far as the flow, that's the second thing that you're going to look at. That's to improve work of breathing. Now, this won't make them magically stop breathing fast. It won't necessarily make everything appear absolutely better, but you should see that after a short period of time that you start seeing just a little bit of relief on these patients. You should see some improved aeration, a little bit of decreased work of breathing. And really what we look at probably more than anything is that they're alert and playful again. Looking at the child and making sure that they look like they are a little more childlike and playful and not just laying there and very lethargic is really a good indicator of whether or not this is working. We start the flows somewhere between 1.5 and 2 liters. We assess every 15 minutes for the first hour in the ED. The max just depends on the local practice. It often, in acute care areas or areas that don't have as much monitoring, will go to a 2 liter per kilo max. Sometimes in the ICU areas or where you have more monitoring, you can go a little higher if needed, but again, you want to really make sure that you're not giving too much flow where you're actually exacerbating the problem and making it harder for them to breathe against. Feeding can vary widely, and I will turn it over to my partner here for this one.
Yeah.
Yeah, I could talk a little bit about this. So, oftentimes if a patient's coming in, breathing 60 times a minute and looking distressed, that's not a patient that I'm necessarily I'm going to feel comfortable allowing to take PO, with the concern being that they're just not going to be able to control the food with the flow and the work of breathing, and they have the risk of aspiration. That being said, that hasn't been often shown in the literature. So we're getting a little bit more liberal in terms of who we allow to feed on high flow and at what flows it's appropriate. So it's just for me, it's a little patient dependent. The patient who has a respiratory rate in the 60s, but is, grunty and tracheal tugging is probably not the kid that I'm going to feel comfortable with, versus the patient that's breathing in the 60s, has some subcostal and intercostal retractions, but it is overall alert and playful. That patient I'm going to feel is what should be totally fine. And I was going to touch a little bit more on this in a slide later on. But sometimes if a patient is super hangry, then allowing them a little PO just to calm them down and decrease their metabolic demand can actually help them not work so hard. So it is a balance. I mean, you just kind of have to use your intuition about which patient's going to be appropriate for that. Sometimes we do use NGs, OGs, or NJs if you do feel like they are high aspiration risk. But I would think about that in line with guidance at your own institution.
Yeah, I think these are all good points. I think the big point, starting from the top, is just looking at the kid, both in identification on whether or not the high flow is helping. It's not just simply looking at the respiratory rate as a single marker or simply looking at the SAT. It's really the overall picture of, is this child more comfortable or not? The goal is not to make them look perfect. And that's really how we initiate high flow. And then, getting into feeding, it's almost the same answer. There's some children who are very, very comfortable and happy being tachypnic and in the ER. Well, we won't necessarily make a big bottle for them, but giving them even just a little bit of Pedialyte, a little bit of sucrose water can just calm them down and get them calm. And honestly can alleviate the anxiety of staff if you're having trouble getting an IV or maybe not comfortable placing pediatric IVs. These are great tips. So what about a drop in O2 saturation? Jen, how do you approach this when you first hear a kid on high flow drops their sats?
I think the first thing that we look at is really the patient getting the flow that we expect them to. So making sure that the cannula is in the nose and not, off to the side and they're just getting kind of a blow by. We'll also look to make sure that they're not bent or occluded or, in an incorrect position. We'll increase the FiO2 in small increments, so 5 to 10%. And then if it's escalating above 50%, we typically will ask that the nurse call the provider, the RT here, but that's also a local standard. And that's just to make sure that everything is really working the way that it's supposed to. If apneic, of course, we'll begin bagging and call for help. And one of the things that we teach our staff here is really making sure, as Suja just said, making sure that the kid's calm. Sometimes when they're crying, they open their mouth. They may be forcing out some of that flow, or they need more flow because their mouth is open. So really looking at those things and making sure that the patient's calm is going to be ideal.
Yeah, great points. And make sure that you have a bag valve mask set up in the room too. In addition, if you have a kid on high flow, make sure that your room is prepared for some of these complications also. Okay, so this is a common question that we get now that folks in the community are having to manage these devices, which is, what's the flow rate that I start on? What if I've been holding a kid for hours, if not a day? How do I even then use this machine, especially what if the kid's getting a little bit better? So Jen, I'd love to for you to walk us through this, and then Sam, you can add on too if you've had thoughts on this.
Yeah, so we have a little chart here, but realistically, that ideal flow rate is very variable patient to patient. What you're getting here is kind of your higher end ideal flow rate. So if you do start at these, you really want to auscultate to make sure that you're not giving too much flow, and feel free to go below these amounts if needed. So these are not, if you have a 1 kilo kid and you set it on 2 liters per minute, doesn't mean that that's not going to be too much for them. So just because that number's there doesn't mean that it's an absolute. It's really just a starting point for you to go max and then kind of turn down. And then it goes up by size. At Dell Children's, in the acute care areas, we do cut off our max flow at 14. Again, these cannulas can go higher than that. Some of them can go as high as 60 liters per minute. However, we rarely will use that type of flow. And if you have to go higher than that, you really want to make sure that you have some more monitoring and some more expert eyes that are constantly watching them. Sam, do you have any feedback on the flow rates before I go into the holiday?
No, all that is great. There was a study that came out a few years ago that looked at flow rates and where patients were seeing improvement in their work of breathing. And less than 8 kilos, it was often about 1.5 per kilo. And then above 8 kilos, it was closer to 2 per kilo. So that's kind of where we find this, and where anecdotally we see that improvement is somewhere around that 1.5 to 2 liters. But I often recommend to just try to finesse it. Listen to your patient, turn up the flow, turn down the flow. Maybe, if you're set at 10, go to 12, go to 8, see if it changes your patient's work of breathing, see if it changes the aeration on auscultation. And you can often get a sense of maybe you're providing too much flow. And so the patient's kind of fighting against it. Or maybe they really do need higher flow, and that improves their work of breathing and helps calm them a little bit. So good starting point, but finesse it a little bit using your clinical exam.
Mm-hmm. And then Jen, you talked a little bit about holidays. So, some of these places may be holding kids for hours or maybe days on high flow. Any thoughts on that?
Yeah, so the American Association of Pediatrics this past year came out with a study looking at high flow cannula and how long should we keep them on these devices and how do you wean it. And so the common thought was once they don't need it, they don't need it at all. And so they did some studies looking at let's try turning it off and see how the kid does. And there really wasn't too much difference once the kid got past the initial need. And so our process here at Dell Children's is every once a shift or BID, after the first 4 hours, we're really trialing the patient off or severely decreased. So if they're on 2 to 8 liter flow rate, then we go straight to room air. And in that first 5 minutes, are we seeing an increase in heart rate, respiratory rate? Do they look like they're in distress? If so, then we put them immediately back on and we wait to do weaning. If they're on higher flows, we can still do these tests. We just go to a 2 liter regular nasal cannula for a trial and do the same thing. We look at heart rate, respiratory rate. Are they having decreases in their FiO2s? And so we do this once a shift just to make sure that we're not lingering on this high flow, which can be a problem.
Yeah, I think what you said was probably the best point, which is at some point during this illness and disease, once they don't need it, they don't need it, right? And so understanding that there's a peak of this illness, and then eventually that peak goes away. Sam, I don't know if you have, you're the ones who end up getting these kids off high flow eventually. Kind of some guidance on the signs that you see that kind of maybe indicate to you, okay, this may be the time that it's time to consider doing a holiday.
I think I had seen a question about the peak of this illness, and
Yeah.
we usually think about these viruses being their worst sometime around 3, 4, 5 days of illness. So if you're seeing a kid on day 2, I'm going to be a lot more concerned that that patient may really be getting worse versus if you have a patient that's on day 5, maybe you just need to help them over the peak. But even in the ICU, we have seen a lot of success from this protocol of just trialing them off. Now that's not a patient who was really sick on BiPAP.
Yeah.
These are your patients that seem to be more comfortable. They are active. They want to play. They're interested in eating. Even if they don't look perfect, they still have a little tachypnea or some, mild intercostal retractions. Sometimes that is no different on room air or on 2 liters of a regular cannula versus high flow. So don't be afraid to try. You can always put it back on if they look significantly worse.
Yeah. And probably the last caveat I'll say for our community providers is that I don't think I would have ever imagined we'd be having a talk about putting people on a holiday for a community ED. So we're really bringing this up in the context of the current state. Most of us in the ED are initiating this while kids are in their peak. And so we're really talking about this in the context of people who are boarding these patients for an excessively long period of time. Again, still getting guidance from your referral centers, understanding that the children's hospitals may just have more resources and time to do this. But we are finding that some communities are getting caught in these situations. So we wanted to talk about this, especially if you're holding kids for a long period of time. So although you cannot see this PDF clearly, I'm going to just mention this to kind of close this topic out of weaning. This attachment will be provided as a supplement to this video. But Jen, can you just talk a little bit about this algorithm of how we think about weaning in a holiday?
Sure. So like I said, we if a patient's been on high flow and it's been more than 4 hours, we don't touch them in the first 4 hours. You spend all that time trying to find the perfect flow. We don't want to backtrack. But after 4 hours, we'll look at some criteria to see if they're ready. Again, they have to meet a certain criteria, like Sam was suggesting. The patient looks good. They look like they're playful. And then they also meet this criteria that the patient is less than 40% FiO2, that they're setting well on that state, their heart rate is within normal limits, and that we have a bronchiolitis score here that helps us guide. And so as long as they're under a certain number on that pathway score, then we would start. If they're not meeting those criteria, we leave them alone. They're still in they're still in a higher setting of the bronchiolitis disease or pathway. And so if they do meet the criteria, then we look at whether or not that all flow with FiO2 above 21% will go to a 2-liter cannula. So if they're needing oxygen, we don't want to take all oxygen away. And so we would go to that 2-liter cannula. If the flow rate is really high, then we would also go to the 2-liter cannula, and then we'd monitor them for a minimum of 5 minutes to make sure that we're not going to see some kind of delayed deterioration. And then we will go back and reassess them every 30 to 60 minutes to make sure that they're still staying on there. If they at the end of that, they would either not pass, in which case we would return to our previous high flow setting. And not passing would be, now you're seeing pretty severe work of breathing, so an increase in retractions or severity. Their heart rate goes up by at least 20 beats per minute. They have an increased respiratory rate by more than 10 beats per minute. That would indicate we need to go back onto the high flow. They may pass, but need to stay on the low flow nasal cannula, which means all of their vitals are in the right category, but they're still not keeping their sats the way that we want to. Then we would keep the nasal cannula on them. Mm-hmm. And then if everything is in place and we're still seeing SpO2s above that 90, we would further wean them down on their nasal cannula like we normally would by like 1 liter per minute until they're off.
Great. Yeah, that's a great way of kind of explaining them what do you do as you're weaning. We'll have this as a supplemental attachment. We'll also have a supplemental attachment of our bronchiolitis score. Just keep in mind that the score that we use is extremely local. It's not a validated respiratory score in the literature, but we use it to communicate on how the kid is doing. Most importantly, how they're doing over time, to just keep that in context. So let's kind of get into the expertise of the ICU providers and signs of a child worsening and high flow nasal cannula escalation, because this is what most of us worry about. So Sam, you kind of walk us through like what are some of your red flags, and then how do you approach escalation when the kid actually, instead of looking better, seems to be looking worse?
Yeah, I feel like this is so our bread and butter that some of this feels very routine for us. But if you're not seeing these kids all the time, then it can be a little hard to tease out, what is progression of respiratory distress. And when we talk about that, we're not necessarily talking about just tachypnea. I've seen patients breathing 70 times a minute, but for all intents and purposes, they otherwise look pretty good. So I don't love them breathing 70 times a minute, but they're still alert and they're still kind of playful and they are robust and not, they're not like that lethargic patient with decreased alertness who just kind of looks puny. Those are the patients that I'm going to worry about. So I would say if you're having tachypnea, significant tachypnea in conjunction with some of these other things on this list, that would be more concerning. If you have a decreasing O2 sat despite an FiO2 above 50%, that is more concerning. If you need to turn your FiO2 above 50%, obviously do what you need to do to support the patient and help them saturate normally. But that does indicate to us that there may be something else going on, or they may be a bit sicker, and they may need more support. Apnea, specifically, we see this in RSV in very little babies. It's actually not uncommon for those kids to have apnea. So you just want to be prepared for that. Again, have a bag mask available for those patients. Make sure you have a mask that is size appropriate for the little kids. Better than me, if you can bag a patient, you can save a patient. So just make sure you have those tools in case you get into this setting. Sometimes with those patients that are having apnea, if we can get them on some flow, you can decrease the apneas, and sometimes not. It just persists, and oftentimes those kids end up being intubated. Rapid worsenings, again, this is kind of subjective, but if you feel like you're increasing flow and they kind of look better, and then they're worse, and you increase flow and they're worse, and they just seem like they're escalating and their work quickly, then we worry that those kids are going to progress to needing BiPAP or intubation. And then important that these devices work pretty quickly. So if you're not seeing improvement in the first 90 minutes to a couple hours, then you're probably not going to see improvement on that, on whatever that support is that you're on, and you're probably going to need more. So if we're seeing any of these signs, one thing is just to try to increase your flow. Remember, I think about flow and FiO2 in silos. FiO2 I titrate to SATs, flow I titrate to work of breathing. So often I'm going up in 2 liter per minute increments, or down, just depending on what you're seeing. But often up if the patient seems to be doing worse. To a max. And for me, that's usually 2 liters per kilo. Anecdotally, I don't usually see any significant change over 2 liters or 2 per kilo for a patient. So if I'm over that, or if I'm at that threshold, I'm normally thinking about BiPAP. So think about, define a max at your site. And if you are on that max flow or max FiO2, consider a chest x-ray. It's not uncommon for these kids to have, maybe not common, but it's possible for these kids to have secondary bacterial infections or pneumonia, right? Something is making these kids worse from RSV than every other child in the community. So maybe it's just the RSV, but it's possible that they have something else going on as well. And then consider a blood gas. This doesn't necessarily have to be an ABG. A VBG or a CBG will give you a ballpark on what their CO2 level is. And that is helpful to clue you in on whether or not they're keeping up on their ventilation. And then you'll want to think about BiPAP or CPAP if you're reaching those max flows. And I'll talk about that in a slide later on. And then ensure good PIV access. You're thinking about, what am I going to do with this patient if they're not better? Am I going to need to intubate them? Am I going to need other things? And so ensuring you have good IV access is important at this stage.
Great. Yeah, these are all perfect red flags, hopefully for the kids that we don't see, but in the case you get caught in these situations, keep these things in mind. So why don't you walk us through some of your top tips as you get patients referred to you?
Yeah, I would say that, by and large, I would probably 2/3 of the patients that I see in the PICU or more, we can get by on high flow. So really the patients that are needing progression to BiPAP or needing progression to intubation, that is really the minority. Mm-hmm. And sometimes once they get to me, I'm actually decreasing the flow, or I'm doing these simple things, suctioning them to make sure they're actually getting the flow, treating their fever. If a kid is febrile to 103, they're going to be working harder and generally feeling uncomfortable, hydrating them if they look dehydrated, or considering a feed if they look particularly hangry and otherwise seem like they could tolerate it. This is really all about decreasing their metabolic demand. And if you can do some of these things, they won't work so hard, and they'll look better in front of you, and you'll feel better. Other things, consider albuterol. The literature doesn't, support that albuterol is globally helpful in these patients, but in your especially older children, which we are seeing more of right now with RSV than in previous years, and for those that have either a family history or a personal history of allergies, eczema, asthma. Sorry, I left asthma off the slide here. Those are the patients that I'm going to try albuterol just to see if it helps. And so you just want to listen before, give them a treatment, even, 5 milligrams, and listen afterwards and see if you see any improvement. And if so, maybe that's something that you can continue to really help decrease, improve their work of breathing overall. We already talked about thinking about secondary bacterial infections or pneumonia that could be worsening their work of breathing. And then this is that study that I talked about earlier, looking at less than 8 kilos and greater than 8 kilos and where they saw improvement in terms of the high flow cannula flow rate. But again, really try to finesse it. Like I said, I've seen patients admitted and then I turned down the flow by 4 liters and they look better. They were just fighting the flow. The flow was more turbulent and making it harder to breathe. And then, as the ICU doc, I always have to say, prepare for no improvement, right? So again, think through those steps. Do you have masks for your bag masks that are appropriate size for these patients? Intubation equipment that's going to be appropriate for these sizes. And then, who is your lifeline? If you're stuck in a situation where, you really don't know how to proceed, who can you call to try to help you virtually until you can get this patient somewhere where they can offer them more support?
Yeah, these are great tips. So the question about BiPAP comes up a lot. And I think you could understand that if you're in the community ED setting, seeing adults where there may be more comfort using those interfaces. I do think that the approach and when we use this in kids is a little bit different. And so I really would love your input on the thought of BiPAP in the community ED setting. Jen, you can kind of add on to, again, I think these represent a very slim minority of the overall patient population. However, we do know that these patients are existing. So I thought we'd make a little note of it.
Yeah, I think, again, usually high flow, oftentimes by and large, high flow is going to be enough to get you through. But when you think a patient just needs a little bit more support, but may not need intubation, but just needs a little more support, you can think about BiPAP or CPAP. Like, this may not be something that you're going to feel comfortable with on children, or that you even have the interface or equipment to do. Obviously, different sized children require different masks. Even at our hospital, which is a pediatric institution, sometimes we have trouble finding just the right mask to fit the patient. So step one is really figuring out if you even have the interface or equipment to do this, or you're really going to be bypassing these, and these are the kids that you're going to end up intubating, or really just checking blood gases on, making sure they're ventilating, making sure they're oxygenating, and trying to buy them, temporize them with high flow. My second tip is choose BiPAP, and that is totally a personal thing. This is probably widely different depending on which intensivist you talk to. But because high flow is maybe providing some kind of inconsistent PEEP, especially on higher flows, if I've already got that, I'm probably just going to choose BiPAP.
Yeah.
And then I just pick a place to start. 12/6 is my happy place. That's usually what I throw out. And then I listen to the patient to assess whether or not I need to adjust. So if they're not having, if they don't have good aeration on the settings, or if we're on a lot of FiO2, I'll increase their EPAP or their PEEP to see if I can improve their aeration or decrease their FiO2. And then you can look at the measured tidal volume on your circuit. Now, you need a good seal in order to reliably look at your tidal volume, but I usually adjust my IPAP or my delta P to target 6 to 7 mLs per kilo for these patients. And then obviously titrating your FiO2 to your appropriate saturation, that's the easy part. And then you have to decide if it's working. So I think of somewhere around like 18/8 being pretty decent BiPAP settings. And if I've given them, really 30 minutes to max an hour without improvement, or you still have a blood gas, it's looking like they're not ventilating adequately, it may be time to intubate them.
Yeah, great. These are great tips. Again, I think step one is where you have to talk about first, which is if you have the equipment and the team to help them. But if you do happen to have it, I think this is a great place to start. And I'm always amazed by how you can get these masks to fit. That's, to me, the art of this all. So I want to thank you. I know this is a little bit long, but hopefully this is a great resources for providers who are having to do this in the community. I want to thank Sam Dallafeld, our pediatric critical care physician here, Jennifer Simpson, our RT director here at Dell Children's in Ascension, Texas, and at Dell Medical School. We hope you find this helpful. Please leave comments and further questions in the comment section. And good luck to you all this winter season. Thank you a lot. Appreciate it.